Okay, madam. Should we start, madam? Hello.
Can I start, sir?
Yeah, just a minute. Madam, should we start? Hello, madam.
Yes, you can start.
Okay, madam. Thank you very much. Good evening to all. Today, our 12th NEBOI webinar is going to be start. So our external expert is Professor K.K. Handa, who is the chairman, Department of ENT and Head and Neck Surgery, Medanta Medicity, Gurgaon. He was the president of Indian Academy of Otolaryngology and Head and Neck Surgery. He was the president and founder secretary of Association of Phonosurgeons of India. He is an international faculty and guest lecturer of voice and laryngology. Faculty member, All India Institute of Medical Science, New Delhi from 1996 to 2009. He has more than 100 international and national publications in index journals. He is the author of Laryngology and Voice. He was the organizing chairman of World Phonocon February 2017. He is a board member of International Association of Phonosurgeons. So I welcome Professor K.K. Handa, and we are grateful, NEBOI is grateful, sir, to you because in spite of your busiest schedule, you have given the consent to be the external expert. Thank you very much, sir.
Now I request Dr. Anjan Jyoti to introduce our speakers, Dr. Ratan Medhi.
Am I audible, ma'am?
Yes, yes.
Yes.
Thank you. So, good evening, everyone, all the NEBOI members and Handa sir. So, in our continuous medical education program, today is mostly the 30th class. So, today's speaker is Dr. Ratan Medhi, who is working as a senior resident in AIMS Guwahati. So, he did his master degree from NEGRIMS in the year of 2022, and after that he joined in Hyatt Hospital, and again he worked in a NEGRIMS again as a resident doctor, and thereafter he joined AIMS Guwahati. During his short course of time after post-graduation, he had a lot of publications. As per his biodata, I have seen 23 publications in the name of Ratan Medhi. So it is a great thing. He is doing a great job. So I welcome Dr. Ratan Medhi to deliver his lectures, and everyone will be benefited. So I welcome Dr. Ratan. Please come.
Thank you, sir.
Let me introduce our moderator today. Our first moderator is Dr. Jerine Linra. She is Associate Professor, Department of ENT, NEGRIMS, Shillong, and she passed her MBBS from Jipmar, Puducherry, and she did her master degree in ENT from PGI Chandigarh. She is organizer of midterm EOCON held on 4th and 5th October 2024 in Shillong as organizing secretary. Areas of interest, rhinology and thyroid surgery, and medical education. She has several national and international publications, and she is involved in several extramural and intramural projects of ICMR, SPI, and co-PI. Let me introduce another moderator. She is Dr. Devika Borua. She is presently working as ENT consultant in Nightingale Hospital as well as Pratiksha Hospital in Guwahati. She is trained under Dr. J.K. Menon in laryngology, and she is the first to start Botox clinic for spasmodic dysphonia in Northeastern region. She was organizing secretary of Phonocon 2024 19th annual conference, and she is secretary of Dhoni, a society of health workers, and she has several publications in index journal. I welcome Dr. Devika Borua and Dr. Linra to moderate today's session on inflammatory condition of larynx.
Thank you, ma'am.
Dr. Ratan, please start.
Okay. Good evening, my respected teachers, all my seniors, my colleagues and juniors. Today, I am going to present a topic on inflammatory condition of the larynx. Now, coming to the topic, what is laryngitis? Actually, laryngitis is the inflammation of the larynx, which lead to edema of the laryngeal mucosa with and along with the underlying structure. Laryngitis, we usually divide it into acute and chronic type. In acute laryngitis, acute laryngitis is usually infective in origin. It can be because of viral infection or can be because of bacterial infection. The infection can be primarily in the larynx or it can be as a complication of neck space infection. And acute laryngitis, it usually involves the vocal fold and supraglottis and subglottis. The clinical features of acute laryngitis, it usually presents with change in voice, that is dysphonia. There will be respiratory distress or difficulty in breathing, that is dyspnea, which is the earliest sign in case of acute laryngitis like epiglottitis. Then there will be sore throat, difficulty, pain while swallowing, that is odynophagia, and referred otalgia. On clinical examination, there are certain signs like the framework of the larynx. There will be tenderness or palpation. The patient may present with stridor. There can be cervical lymphadenopathy and pooling of saliva. Uh, uh, this acute laryngitis, it usually presents in pediatric age group. And why it's concerning? Because this pediatric age group, the laryngeal framework, it lacks firm cartilaginous skeleton. Then this is flabby and easily collapsible structure, and the glottic aperture is narrower than the adults, and mucosa usually swells up rapidly in response to slightest of the trauma or infection. And that's why they usually present with stridor. Now coming to acute, since I have already told, it can be like because of infection. Infection can be because of viral or bacterial. So acute viral laryngitis, it usually self-limiting within few days. There will be rough, deep voice of variable pitch, which often disappear during the mid-sentence. This voicens and symptom of viral laryngitis usually preceded by common cold symptoms and sore throat. On examination, there will be erythema and edema over the vocal cord, and there can be excess of secretions in the larynx. Then acute viral meningitis, usually it is self-limiting, resolves within 1 week. Then usually our treatment will be more kind of supportive and supportive management. Usually, we ask the patient to maintain the vocal hygiene. Then we advise for voice rest and maintain hydration. We can also give analgesic and anti-inflammatory. Steam inhalation is usually we advise, but most of the reports are of steam inhalation. It's reported in group in children, and it doesn't show any good evidence of benefit. Then erythromycin also can be advised because it has antiviral property along with inflammatory property. And if the patient present with stridor, we have to admit the patient for IV antibiotic and for nebulization, adrenaline or epinephrine nebulization. Along with all this symptomatic management, we have to ask them to stop smoking. Then allergy, rhinosinusitis, and voice abuse, LPR, should be managed appropriately. And usually acute laryngitis, these professional voice user, they present for a urgent treatment. So management will be little bit drastic, and we start with systemic steroid, antibiotic, mucolytic. Antibiotic can be like amoxicillin, ampicillin, erythromycin, tetracycline are suitable. Antiviral we usually don't prefer because of its significant side effect. Now coming to the types of acute laryngitis, like first is epiglottitis. The epiglottitis we usually found in children, and like incidence rate is 1 to 9 cases per 1 lakh of population in adults, whereas in children it is 6 to 23 per cases per 100 population in children. The most common causative agent of epiglottitis is Haemophilus influenza type B, and but after the invent of Haemophilus influenza B vaccination, the incidence of epiglottitis has been drastically reduced. In children, the disease progress very rapidly and compromise the airway, and they usually present with stridor because of the laryngeal structure, what I have already discussed. And streptostaphylococcus also can cause epiglottitis. Viral cause is usually very rare. The clinical features of epiglottitis usually they present with sore throat. It will be dysphagia, odynophagia, and pain in throat. Usually, we don't do endoscopic evaluation if we suspect epiglottitis because it may worsen or a patient we may precipitate stridor. But if we examine, we can see reddish swollen epiglottis, and larynx will be extremely tender. On neck examination, there will be cervical lymphadenopathy, there will be drooling of saliva, edema of the palatine arch and uvula. If we found in suppose in epiglottitis patient, if the tachycardia is disproportionate to the fever or pyrexia, it's an important sign that precedes airway obstruction. In investigation, it's a clinical diagnosis, but on investigation, sometimes we ask for X-ray soft tissue neck. In lateral view, we can see the thumb sign with enlarged epiglottis or follicular sign, that is deep, well-defined follicula. Here we can see this epiglottis is edematous and bulky and congested, and in this X-ray we can see the thumb sign. Management, usually if patient present with stridor, we have to do airway securing by intubation and tracheostomy. IV antibiotics should be given with 100% humidified oxygen. Antibiotic of choice is third generation cephalosporin and chloramphenicol, or metronidazole can be considered if we suspect some anaerobic bacterial infection. Main complication of epiglottitis is epiglottic abscess, which is seen in 4 to 27% of cases. Usually it occurs on the lingual surface of epiglottis, and there can be pulmonary edema and thrombosis of the IJV, that is Lemierre syndrome. Now coming to the laryngotracheobronchitis or croup, this group is usually viral. The infection is mainly caused by the virus, which is parainfluenza virus type 1 or type 2. Paramyxovirus also can cause laryngotracheobronchitis or group. It's usually seen in children of 3 months to 6 years of age. Clinical features, they usually present with hoarseness, barking cough, then stridor, and varying degree of airway distress. And since it is viral origin, it usually preceded by history of URTI. And if we see group in adult, you have to suspect some kind of impaired immunity in those patients. Then on examination, there will be inflamed focal port, subglottic edema, which extends to the trachea. On investigation, we can directly detect viral antigen from sampling mucosa from the nasopharynx, and in X-ray, APV, we can see staple sign or pencil tip sign. Here in the X-ray, we can see the staple sign or pencil tip sign. In group, we have a like symptom severity score, that is Wesley score. In Wesley score, we usually give scoring of 0 to 5, and the features include sexual retraction, stridor, cyanosis, level of consciousness, and air entry. Others are given 0 to 1, 2, 3 like that, but the cyanosis, if it is none then 0, but if cyanosis is present with agitation, it is given score of 4, and at rest, it is given score of 5. So total score is 17. We considered it to be a mild variety if the score is 2 to 3, and we manage with supportive treatment. In moderate, score is 4 to 7. We consider it as moderate. We have to give steroids and nebulize with epinephrine. And severe cases, we have to manage in ICU. So in treatment, we have to give oxygen, steroid, nebulization with adrenaline. And broad spectrum antibiotic are advisable to cover the secondary infection, but usually it's self-limiting. 50% children improve within 24 hours, and mostly they recovered within 4 days without treatment. Recurrent, there is something recurrent group which is like repeatedly happening. Usually we see recurrent group in congenital or acquired mild subglottic stenosis patient or laryngeal atresia patients. Recurrent group, we have to give supportive treatment, reassurance to the patient party. Child should be nursed in humidified environment, and if there is subglottic stenosis or atresia, then we have to manage accordingly, like laryngotracheal resection and application of mitomycin C. Then among the steroids, we prefer dexamethasone of 0.6 mg per kg, maximum of 16 mg, which onset is 30 minutes and act for around 72 hours. So dose should not be repeated. Single dose is enough. Then for nebulization, we can use racemic epinephrine 0.05 to 1.1 ml per kg, diluted in 2 ml of NS, and should be given 20 minutes per Q 20 minutes. Then after the treatment of this group, how to decide when to discharge the patient? We discharge the patient when there is no stridor at rest. They are able to tolerate per orally food. And then last racemic epinephrine is given more than 2 hours before, and only less than 3 racemic epinephrine has been given. And alternative diagnosis for group were like when we suspect some other disease instead of group, if the age is less than 6 months or more than 6 years, then stridor is there for more than 4 days, cough is there for more than 10 days, and then because it usually should subside by 4 days, then if there is recurrent group, there is toxic, patient is toxic in appearance, there is asymmetric respiratory examination and poor response to treatment, then we should think of some other diagnosis. Then coming to the bacterial laryngotracheobronchitis, that is group is viral laryngotracheobronchitis, and bacterial laryngotracheobronchitis we also known as pseudomembranous group or pseudo group, and neonatal necrotizing tracheobronchitis or tracheitis. And it is usually life-threatening. It is bacterial in origin, and usually present with profuse mucopurulent secretion with sloughing of respiratory epithelium. In this chart, I have divided group epiglottitis and tracheitis and their difference. Here we can see voice in group it is hoarse, and epiglottitis it is muffled. Cough is barking in group, barking type in group. Epiglottitis it is suppressed position. It is symptoms are in supine position. In epiglottitis it's sitting or neck extended position. And X-ray soft tissue neck. Epi view we can see staple sign in group, and lateral view thumb sign in epiglottitis. Now, coming to the other cause of acute laryngitis like pertussis or whooping cough, it is caused by Bordetella pertussis. The clinical features is usually little bit milder, and it's present as URTI or dry cough. The cough is usually prolonged paroxysm followed by gasping or whoop in children, but in adult it is protracted cough, which means it is not responding to any treatment. And investigation for Bordetella pertussis, it mainly diagnosed with serology, polymerase chain reaction, and nasopharyngeal aspirate culture. Treatment, we give erythromycin for 7 to 14 days. Prophylactically, to prevent the disease, also we can give erythromycin. And usually erythromycin doesn't change the character of the cough or clinical course of the disease. Then diphtheria, though it's a rare cause of acute laryngitis, but sometimes it may happen. Usually it affects the oropharynx, tonsil, pillar and all, but sometimes it can also spread to the larynx. Usually presents with severe throat pain, malaise, pyrexia, and it is usually characterized by a pseudomembrane over the tonsil. Investigation, we do swab test and staining like Albert stain, Ponder stain, Niger stain, and we can see sinus lateral pattern. And treatment, we treat with benzyl penicillin 10 to 1 lakh unit and endotoxin. And the complication of diphtheria is usually like because of their exotoxin, myocarditis, arrhythmia, death, and can be neurological like peripheral neuritis, soft palate paresis, and sometimes it can cause extraocular muscle weakness too, and diaphragmatic paralysis. That much of in the acute laryngitis. Now coming to the chronic laryngitis. Chronic laryngitis, it can be of non-infectious origin. Then it can be because of bacterial infection, fungal infection, mycobacterial infection, or it can be a part of some granulomatous systemic disease, which can present as chronic laryngitis. Among the non-infectious cause for chronic laryngitis, the what can cause chronic laryngitis are laryngopharyngeal reflux, LPR, then smoking, then polluted air, vocal abuse, and rhinosinusitis. Then chronic laryngitis, the clinical features, it usually like in contrast to acute laryngitis where patient present with stridor, then difficulty in breathing and all. Chronic laryngitis usually they present with transient voice or dysphonia. There will be foreign body sensation in the throat, difficulty in swallowing, then repeated throat clearing, halitosis, bitter taste, and otalgia. If we do flexible endoscopy in case of chronic laryngitis, there are grading system for chronic laryngitis in flexible laryngoscopy. In grade 1, we see mild erythema, grade 2, diffuse edema and mucosal thickening. In grade 3, diffuse erythema, and grade 4, there will be discrete granuloma formation. But and in histology for chronic laryngitis, grade 1 there will be thickened epithelium, grade 2 cellular atypia, and grade 3 severe dysplasia we may find in chronic laryngitis. Now, about the laryngopharyngeal reflex, among laryngopharyngeal reflex is usually present in more than 50% of the patient who present to our clinic with dysphonia or transient voice. The most common symptoms for laryngopharyngeal reflex is repeated throat clearing. Most common is hoarseness of voice, which is characterized like hoarseness is seen mostly in upright position daytime. Then there will be repeated throat clearing and coughing. Hoarseness is seen in almost 70% of the cases, throat clearing around 47% case, and coughing in 50% of cases. And there can be globus pharyngeus, that is lump in throat sensation. There are laryngo symptom reflex symptom index, where we give depending on the symptom we give scoring, and maximum score is like 45. If it is more than 10, we diagnose as laryngopharyngeal reflex. And there is laryngeal reflex finding in sorry sir. Then diagnosis of laryngopharyngeal reflex is usually for by examination, laryngeal examination, barium swallow. There is multichannel intraluminal pH monitoring, esophagoscopy, and trial. Then PPI trial with PPI. On an endoscopic examination, we can see there will be edema, erythema in the posterior commissure. There can be granulomas, contact ulcer, pseudosulcus, or subglottic edema. So, laryngeal pharyngeal reflex is dreaded complication are like they can lead to subglottic stenosis, laryngeal spasm, bronchiectasis, chronic rhinosinusitis, and all. Then diagnosis is also we can do 24-hour pH study where we measure the percentage of time where the probe is exposed to pH of less than 4, that and if the time is more than 1%, then we consider it as laryngopharyngeal reflex, and sensitivity is around 40%. But if we combine the pH monitoring along with laryngoscopy and reflex finding score, then it contribute to identify all the patient with potential response to PPI, and the sensitivity increase to 90%. And usually we prescribe proton pump inhibitor, that is twice BD dose, in contrast to GERD where we may prefer for OD dose, and uh, H2 blocker and prokinetic drugs. Here we can see the imaging where we see findings of laryngopharyngeal reflex with edema, inflammation, proscricoid granulation, and all. Then coming to the bacterial cause of chronic laryngitis, it can be because of syphilis. Syphilis is one of the cause for chronic bacterial laryngitis. It usually affect the supraglottis, that is epiglottis and aryepiglottic fold. Syphilis has stages. Secondary stage we can see erythematous papule, and in tertiary stage we see nodular infiltrate which coalesces to form a painless ulcer in the tertiary stage. Syphilis usually treatment is benzathine penicillin treatment of choice, 2.4 million unit weekly for 3 to 4 weeks. If patient is penicillin resistant, then we can go for doxycycline or tetracycline. Then actinomycosis, one of the other bacterial cause for chronic laryngitis. Actinomycosis is caused by actinomyces israeli or bovis. Then larynx is rarely involved, and clinically the larynx can be erythematous, swollen, or wooden appearance. Actinomyces, if we see do histopathological examination, we can say the sulfur granule, and treatment of choice, drug of choice is penicillin or clindamycin in case of actinomycosis. Then Klebsiella rhinoscleromatosis, one of the rarest cause for chronic laryngitis, bacterial laryngitis. It involves glottis and subglottis mainly, and diagnosis is mainly histological, where we can find Mikulicz body and Russell body, and treatment mainly include aminoglycosides. Now I have included this non-infectious laryngopharyngeal reflex, bacterial. Now coming to the fungal cause of chronic laryngitis, where we include histoplasmosis, blastomycosis, cryptococcus, coccidiomycosis, and candidiasis. That histoplasmosis, it usually caused by histoplasma capsulatum. It can be acute, it can be chronic. Pulmonary involvement can be there, systemic manifestation can be there. If it involved the larynx, it usually involved the anterior larynx and epiglottis with nodular granuloma. And in biopsy is the diagnosis. We diagnose with biopsy, where we see poorly defined granuloma, multinucleated giant cell, and pseudoepitheliomatous hyperplasia. In X-ray, we may see calcified opacity in the chest. And treatment is mainly amphotericin and azoles, ketoconazoles. Blastomycosis, it is caused by blastomyces dermatitis. True vocal cord is mostly involved, then ventricular fold. The lesions are usually exophytic, which can be mistaken for squamous cell carcinoma. Cryptococcus neoformans, it's mainly because of bird dropping and can cause meningitis, sensorineural hearing loss, along with involvement of larynx, where involved true vocal cord. Diagnosis in staining with Indian ink stain, and treatment is again amphotericin and azoles. Coccidioides immitis. It causes valley fever in Southeast United States. Mainly signs are like nodule or erosion of skin, and if it involve the larynx, mainly involve the epiglottis and trachea. In histopathology, we see sac with bug appearance, and treatment is with amphotericin. Candidiasis in one of the most common cause for fungal chronic laryngitis. Usually we see in immunocompromised patient who are HIV patient and patient who has received radiotherapy, and in immunocompetent patient mainly seen in like who receive antibiotic and then receive inhaled steroid for bronchial asthma, diabetic patient, chemotherapy, smoking, acid reflux and all. In those cases, we may see candidiasis in the larynx. It is characterized by a whitish pseudomembrane or adherent white plaque, which can be misdiagnosed as leukoplakia. It can appear as diffuse erythema and edema, and sometime in severe form, there will be ulceration along with the pseudomembrane. Then biopsy is the investigation of choice, or diagnosis will be by biopsy. Methenamine, silver, and periodic acid skips stain we use, and treatment will be with systemic antifungal therapy if patient is immunocompromised. Fluconazole is drug of choice for candida. Ketoconazole is for histoplasmosis and blastomycosis. Then coming to the mycobacterial laryngitis, usually it causes pulmonary or no, extrapulmonary TB, but TB laryngitis is very rare, and it only causes less than 1% of the total TB cases. But it usually occur because there are two theories, like bronchogenic theory or hematogenous theory. Bronchogenic theory is like when with a patient with pulmonary TB, where they cough with expectorant, the bacteria may dislodge in the larynx and can cause laryngitis. And hematogenous theory is like TB not in the lung, but it spread from somewhere with in the blood. This complaint of symptoms will be like hoarseness, dysphonia, pain while swallowing, difficulty when swallowing, and otalgia. And on examination, we get red. Mainly, it involves the posterior part of the glottis, interarytenoid mammillation, mouse nibble ulcer, turban epiglottitis, and epiglottic granulation tissue in the intererythenoid region. Biopsy is the diagnosis of choice, where you can see caseating necrotic Langerhans type of giant cell and all, and sputum test, Montauk's test and all we can do. And then in this picture, we can see the mouth eaten appearance, then turban epiglottitis and all. Then coming to the leprosy, in the larynx, it usually involves supraglottis mainly, and mostly causes epiglottitis, and we find edematous nodular supraglottis with ulceration. Treatment will be with depson and clofazimine. Then radiation and also can cause one of the cause for chronic laryngitis. Now coming to the granulomatous disease, systemic disease which can cause chronic laryngitis. One of the commonest granulomatous disease is Wegener granulomatosis, which is a small vessel vasculitis, multisystem inflammatory disease, where it usually in larynx it involves the subglottis, and one of the important features is like it is always CNK positivity seen in 90% of the cases, and some we see interferon gamma, tumor necrosis factor alpha, interleukin 12, which can be elevated in the blood. Then a patient present with hoarseness, hemoptysis, cough, dyspnea, stridor, and wheeze. There are three types of Wegener granulomatosis. Type 1, where only the airway symptoms are there without any other systemic finding. Type 2, with type 1 Wegener plus pulmonary symptom like cough and hemoptysis. And in type 3, there will be systemic involvement. Treatment will be by steroid and cyclophosphamide. Methotrexate and azathioprine can be started after the remission of the symptom. Then relapsing pericarditis is a rare inflammatory condition of unknown etiology. It involves ear, nose, throat, larynx, bronchi, costal cartilage. Diagnosis criteria is McAdam criteria, and relapsing pericarditis in the ear, it causes lobule sparing pericarditis. Then it can cause cochlear and vestibular dysfunction, nasal pericarditis, and in laryngeal cartilage frame of pericarditis. Diagnosis, at least three of the criteria has to be there, and there should be a positive biopsy from the ear or nose or respiratory cartilage. And usually larynx is involved in 50% of the cases, and patients with hoarseness, cough, choking, wheeze, dyspnea and all. So in CT scan, we see subglottic stenosis, tracheobronchial lumen narrowing and dense, and thickening of the tracheal cartilage because of pericarditis. Histopathology is confirmatory. Treatment, if patient come with stridor, then tracheostomy and corticosteroid and immunomodulating drug has to be given. Depson is effective if cartilage inflammation is there in some patient. Then sarcoidosis, another chronic granulomatous disorder of unknown etiology. It is characterized by non-caseating granuloma and tubercles. Then in larynx, it mostly affects the supraglottis more than subglottis. Glottis is rarely involved by sarcoidosis, and so among the supraglottis, it mainly involves epiglottis. In microscopic examination, we can see a thick edematous supraglottis with pale and pink color of mucosa, which is pathognomic. Diagnosis may mainly histopathology, and a high dose of steroids should be given. Translaser resection and supraglottic laryngectomy may have to be performed, and tracheostomy if in case of stridor. Then amyloidosis, again one of the cause of chronic laryngitis, where there is extracellular deposition of insoluble fibrillar protein. It involves true focal cord, false focal cord, and ventricle. And patient present with hoarseness and cough. And diagnosis is usually by biopsy, where we can see typical bright green bifringent with polarized light microscopy and are seen after staining with Congo red stain. And in urine, we can see benzone protein. Treatment, again, microdefibrillator excision and CO2 laser excision can be done. Tracheostomy if rarely required if there is stridor. Rheumatoid arthritis, another one peripheral polyarthritic disease, which is usually symmetric and with unknown etiology. If it usually it rarely involve larynx, and symptoms will hoarseness, dysphagia, global sensation. And in rheumatoid arthritis, it can be active or chronic. In active disease, the larynx is tender. There will be congestion, edema, and swollen erythenoid. Whereas in chronic, we usually found nodules in the vocal fold. That is usually we call bamboo nodules or bamboo larynx. Then diagnosis is by histopathology, and treatment we have to do MLS surgery, vocal cord nodule removal. Tracheostomy may be needed if there is bilateral vocal cord palsy, which is seen in in chronic stage where there will be cricoarytenoid joint spondylosis. And treatment can be given with DMARD, hydroxychloroquine, sulfasalazine, methotrexate, infliximab. And my last topic is pemphigus vulgaris, which is also a rare autoimmune disease, which usually doesn't involve the larynx, but usually involve mouth, skull, face, neck, and axilla with bleb and blisters. But in larynx, usually bleb and blisters we don't find because it is sloughed off by swelling, and there we can find fibrinous base with a halo erythema in between. That is the typical features we found in larynx if it is involved by pemphigus. Though I have taken this thing from Scott Brown, then Cummings and Thingraman. Thank you. Thank you, sir.
Thank you, Dr. Ratan. That was an exhaustive presentation. So I would like Dr. K.K. Handa sir to make expert comments first.
Yes, I think he has covered the topic fairly extensively. And,
Yes.
but I'd like to make few remarks. Today, the term chronic laryngitis should be used. Can
Sir,
you hear
your
me?
voice is low. Can you
Can
speak
you hear me
louder?
now? Yeah.
Yes, sir. Yes.
Now can you hear me?
Yes. Yeah, it's
Yeah.
better, sir.
Yeah. So he's covered the topic fairly exhaustively, but few comments
Yes.
I'd like to make today. Be cautious of using the term chronic laryngitis. In every case of chronic laryngitis, there is another diagnosis. Most of the cases, whether if it is related to voice misused type of a picture, or whether it is some bona fide pathology like you described a lot of them. So this term is a term at the most of exclusion. It should not be primary diagnosis. Number two, histoplasmosis. Now, just last week, one patient we thought was squamous cell carcinoma. The diagnosis given was histoplasmosis. That is fine. You said drug of choice, amphotericin, ketoconazole. I think itraconazole is a good drug, better than ketoconazole. It is same group, but a step higher than ketoconazole. Then other thing is white lesion in the cord, and every white lesion is not leukoplakia or verrucous lesion. First thing, suspect fungus, candidiasis. We have seen multiple patients where a week of fluconazole just takes off the lesion, where patients have been dated for microlaryngeal surgery. They come for a second opinion. Even if you are not sure, nothing happens if you make the patient wait for 7 days, give a course of fluconazole, and the lesion disappears. The next comment about pemphigus. Now, you said pemphigus is very uncommon. No, it is not so. Every year, I'll see 3 or 4 cases of pemphigus involving the larynx. So, a pemphigus patient orally, it can be very easily, at least you can be suspicious because it is this condition which is very painful, and these ulcers, they don't go. And you send them to a dermatologist, he starts treatment, Azoran and all the other drugs, and the lesions disappear. But if he has persisting pain in the throat, voice is hoarse, you do a laryngoscopy, fiber optic laryngoscopy, and you'll find these lesions. So laryngeal pemphigus is not so rare. Off and on, we do find these patients. Then tuberculosis. Again, dysphonia with pain. You have described very nicely all the classical laryngeal findings. moth-eaten epiglottis, moth-eaten cords, then a picture of epiglottis like this description was given in Niger's textbook. But one striking feature is the dysphonia is always painful. And even issue whether it is always primary or sometimes it can be secondary, you can have a coexisting uh, chest TB. So even if it is not so common, do your workup, do a X-ray chest, CT if required, and a consult by a chest medicine person. Even rheumatoid arthritis is not so uncommon. Many a time we will see rheumatoid arthritis and you will confuse it because when there is fixation of cricoarytenoid joint, you may confuse it with a vocal cord palsy. So initial appearance is that. And how will you differentiate? You will do a laryngeal EMG. And if you do a laryngeal EMG in rheumatoid arthritis, it will be normal. While in cord palsy, it will be abnormal. And what exactly will depend on the phase, whether there is renervation, you will have polyphasic potentials, or whether it is in the early stage. So anything else you want to ask or discuss, I'm fine with that. But these are few points I noted which
Okay.
needed some deliberation.
Thank you, sir. There are some questions in the chat box. Should I read those?
Yes, please. We can tackle them one by one.
Dr. Ratan can answer. Dr. S.B. Fukan sir is asking how common is whooping cough and diphtheria? Ratan?
It's sir, actually, I feel difficult to answer this because in my practice, I am very new, but still I have not come as such with diphtheria laryngitis. I have not got a single case till now in my uh, yes, sir, but it has to be very rare, sir.
There is another question from Dr. B.N. Sharma, sir. Is there a time frame to differentiate acute and chronic laryngitis?
How we in like CSOM or ASOM, other diseases, how we divide 6 weeks or 3 months. I have not got any written in book how to divide it into chronic or acute. But as usual, for all disease, what we decide 2 weeks or acute or more than 6 weeks or 3 months that is chronic. I think that has to be considered here also.
Handa sir, would you like to comment on that?
Now, I will comment on both the questions. The first,
Okay.
diphtheria is almost eradicated very rarely now. When we were in our residencies in PJ Chandigarh, we used to do see diphtheria cases. Now, it is very rare and more rare because if there is a slightest suspicion and you grow diphtheria organisms, you send them to infectious disease hospital. So normal hospitals will not keep them, and it is very rare. Whooping cough, occasionally we do see a patient. I remember last 3-4 years, at least 2-3 patients. So it is fairly rare. The second question, the dividing line between acute and chronic laryngitis, I will say 6 weeks. But again, as I commented, chronic laryngitis term should be used with a lot of caution. There is a diagnosis to every case of hoarseness with laryngeal findings after a particular time. And at the most, it should be a diagnosis of exclusion. The SLPs, the voice therapists, they were very used to labeling everything as chronic laryngitis. But today, you show them lesions on laryngoscopy, stroboscopy, or with simple pictures, you get a diagnosis. So time, if you have to say 6 weeks, but again, be very circumspect in using the term chronic laryngitis. Yeah.
LPR and GERD are these?
Hello.
Hello?
Yeah, Dr. Mehdi will answer that. LPR and GRD same or no? Or should I answer?
Yeah.
Sir, You will be better person, but sir, I just like in my knowledge, sir, LPR and GRD is not same as such. The total pathophysiology and the whole pathophysiology is totally different, sir. In GERD, usually it extend to esophagus, but LPRD we consider when it is going to larynx and all, and LPR it usually aerosol mediated. The pathophysiology is like that, and in GERD it's mainly because of acid content or acid or pepsin and all, sir. And the symptom is also uh, LPR is usually present like with hoarseness and daytime symptom, upright position symptom, and GERD usually heartburn and all, and in lying down position. I think that much from my side, sir.
So these are two different things.
Yes.
LPR is an extraesophageal complication or manifestation of GRD. GRD is something which is confined to the with the classical symptoms of eructations, heartburn, while LPR may or may not have these symptoms. The symptoms may be more related to throat, like globus, something stuck in the throat, which is probably the most common symptom. And diagnosis is different. To the gold standard for diagnosing LPR, apart from your laryngoscopy with classical findings of posterior laryngitis, interarytenoid mammillations, pseudosulcus, thick mucus. Apart from that, the gold standard is double probe pH monitoring. Very few people do it because clinically it costs money, and then on symptoms you can start treatment empirically. Many of them respond. The second thing is the treatment. The proton pump inhibitors, apart from lifestyle modifications, are given for both. But remember, for LPR, it is double the duration and double the dose. If for GRD you are giving once here your pantoprazole, rabeprazole, esomeprazole, for LPR you have to give it twice a day, and for 6 weeks to 3 months, double the duration.
Okay. There were two questions from BN Sharma sir. I'll ask them together. Is HRCT thorax is helpful in diagnosis of chronic laryngitis? And is flexible nasopharyngoscopy routine or selected in case of chronic laryngitis?
Sir, for all, like sir has already told, we should not term it as chronic laryngitis, but all the patient who presented to us with some laryngeal symptoms, we definitely do some laryngeal examination with endoscopy, whether it's flexible or routine endoscopy. But HRCT thorax, I don't think it's mandatory for all cases. So, specifically, we can advise if we are suspecting the chronic laryngitis to be some because of some bacterial infection like tuberculosis, where we find then sarcoidosis, and in those cases Wagner galleunomatosis. If we clinically suspect something then which can affect this lungs also, then where there can be subglottic stenosis and all, we can go for HRCT thorax.
Okay. There is another question.
Yeah.
From... Sir, you want to comment, please?
See, HRCT thorax is essential when you have a cord paralysis. For chronic laryngitis, normally it is not required unless you suspect tuberculosis.
Okay.
That is all what I like to say. Please carry on with the next question.
Yeah. Next question is Khanna ma'am has asked. I think Ratan has described it, but you can still answer. Clinical appearance of larynx in tubercular laryngitis.
Like I have already described as ma'am, like interarytenoid mammillation, turban epiglottitis, mouth nibble appearance. There will be diffuse edema. I recently got one patient, a small kid. She presented with diffuse edema and whitish discharge all over the larynx, and the larynx looks so dirty. Like by looking at it, we can suspect, ma'am, actually it's TB laryngitis.
Yes, there is another thing you have shown the picture, but you have not said the term, the monochorditis. That is also significant. In some cases of tubercular laryngitis, you get only monochorditis.
Yes.
There is another question from Pukan sir. RAF technology helps in GERD and LPR both. Does it help in GERD and LPR both?
Ma'am, I think I won't be able to answer this question.
RAF
I
technology
cannot-
means the RAFT medication, that is he's saying.
At present, I'm not
Alginates, that means alginates.
Yes, ma'am.
Alginates, do they?
A few studies I have found, ma'am, like alginate, usually if it is taken with PPI, then the efficacy is better than using only PPI or yes, ma'am. But exactly, I cannot answer.
So I will try to answer that. Now, it's a specialized technology where you use polymerization. And these formulations, they act with gastric acid to form a floating gel, which stays in the stomach to release or slow the release of these medications. And it definitely helps. But again, it will help the medicine stay in the stomach for longer and reduces the absorption of the drugs. It is helpful for both GRD and LPR. But again, this is one version. The other version is your standard drugs, PPIs, be it esomeprazole, pantoprazole, rabiprazole, all of them work fine. So maybe even once a daily dose for something which is not very, very complicated, the normal PPIs also work. But theoretically, RAF technology should help.
Okay, sir. Thank you. We don't have any more questions. If Dr. Zareen wants to comment on anything.
Thank you, ma'am. That was a very good presentation by Dr. Radhan, very comprehensive. I think he has covered almost all the important
Yes.
topics, especially for this topic is very important for the PGs also. And he has covered all from acute to chronic and from common diseases to very rare diseases like, your blastomycosis and everything. So I think he has done a good job, and I think we are privileged to have Dr. Handa here today and his expert comments. And I think that's all from my side.
Thank you, Dr. Radhan.
Thank you, ma'am.
So thank you.
Hello.
Yeah, boy. Yeah, Dr. Anjanda will come up.
Hello. Yeah.
Thank you.
We have already covered everything. It's a very elaborate topic, and he has covered everything from acute laryngitis. And though we are not seeing too many cases of acute laryngitis, but knowing the laryngitis well is a good thing for your everyone's practice. So in today's meeting, maybe we are going to conclude this meeting with the.
Anjanda, sorry, there is another question from Khanna ma'am. She's asking, can chronic laryngitis may be precancerous?
Okay. Ratan?
As such, sir, in precancerous lesion of larynx and all, I have not got directly the term chronic laryngitis as a included in precancerous. I have to go through it, sir.
Okay, that's fine. So, Handa sir, can I
Yes,
ask
please.
you one question? Because as you have already told that we should not term these pictures of the larynx as chlorine laryngitis. So, is there any other term we are using nowadays, or how we name them?
The term is what I'm emphasizing is every case which is labeled as chronic laryngitis, 60-70% you will be able to find a focused diagnosis, a specific diagnosis. In case you
Right.
don't find, then you use the term term chronic laryngitis. It should be a diagnosis of exclusion, where
So
you may have
if
some
we
cord
cannot diagnose
findings.
it direct.
Yeah. Where you have some findings, but you are not able to define it. And it is the hoarseness is there beyond 6 weeks, and this is persisting. But today, with so much of improved diagnosis, laryngoscopy, stroboscopy, uh, then so high-speed photography, almost 90% of cases you can give a specific diagnosis rather than just use the term chronic laryngitis.
Okay, sir. In how many percentage of cases of this type of presentation, we need to do biopsies to rule out the diseases in your practice or?
So biopsy we will only do if we are suspecting something which is towards malignancy, and we can be helped by doing a stroboscopy. If you do a stroboscopy, you see the mucosal wave, pliant vocal cords, rest of the features are fine. You can hold on, you can start the treatment. But wherever you have a suspicion, especially on stroboscopy, or a very obvious lesion even on laryngoscopy, you must go for a biopsy.
Right, sir. Thank you very much, sir.
Thank you. Thank you.
Is there any question from Pupon, sir? Okay, I think so. We can conclude the meeting today. So I thank Dr. Handa sir for his very valuable time and his precious knowledge, with his knowledge, and we are very much helpful with his knowledge. Dr. Ratan has done a great job, including all the laryngeal features inflammatory diseases. Thank you, Ratan, for making this presentation very elaborate. I thank Dr. Devika, I thank Dr. Zerin for being moderating this session, and I thank all the NEPA members who have joined this today's session, and we'll be having this type of sessions every 14 days. So with that, I would like to conclude this meeting, today's meeting. Thank you, everyone.
Thank you very much. Thank you.
Thank you.
Thank you. Good night.
Good night.
Good night.
Good night.